It's indeed my pleasure to introduce our keynote speaker, Dr. Sanjay Agarwal, a distinguished fellow of both American College of Endocrinology and the American College of Physicians. He is the director of Agile Clinic Diabetes Care, the head of Department of Medicine and Diabetes at Ruby Hall Clinic, the head of Department of Diabetes and Endocrinology at Sahyadri Hospitals, and a senior consultant in diabetes and medicine at Jahangir Hospital. He currently serves as the Honorable Secretary of the National RSSDI Governing Council and is on the editorial board for BMJ Open Diabetes Research and Care Journal. He's also the associate editor for the International Journal of Diabetes in Developing Countries. Dr. Agarwal has played a crucial role in developing several RSSDI guidelines, and he is the author of the Clinical Atlas in Diabetes. He also serves as chief editor for RSSDI's insulin monograph and has significantly contributed in landmark international research journals. A frequent faculty member at national and international conferences, Dr. Sanjay is also a dedicated mentor for postgraduate programs. He brings invaluable insights from his extensive experience in medicine and diabetes care. Today, he'll share his perspectives on pharma marketing and HCP'S and how tools such as CDSS are crucial for patient centricity. Please join me in welcoming Dr. Sanjay. Over to you, sir.
It's a pleasure to be here, and I would like to thank Swati and Satish for inviting me over here today. When they sent me this invitation, I was kind of perplexed. I said, what is a clinician going to speak to somebody, non-clinical subject? But then the policymaker and me took over as the secretary of RSSDI. I said, let me see what should be the roadmap for the future that the clinician and the pharmaceutical companies should partner in terms of patient centricity. So I think we all know that disruptions lead to innovations. And if you look at the journey of all the disruptions that have happened, whether it's in terms of banking, commerce, travel, entertainment, gone are the days when we sort of relied on traditional ways of working, and the digital tools have taken control and made the system more efficient, more reachable, and probably, reproducible. So we've got the classic example of how banking is done today and what it was earlier. But how has it transformed healthcare? That is very important. And if you look today, the disruption that has happened, similarly, taking the examples from the banking industry, today we know that with digitization, there is enabling of timely and accurate diagnosis. There's access to complete patient health records. There's an online access to doctors through telemedicine and removing geographical barriers. And there's an improved efficiency in the healthcare system. Now, if I walk my journey of last 40 years of clinical practice, when I started way back, we didn't have any digitization at that point of time. It's been a huge journey for us, people like us from the senior faculties, who have seen the entire digital world develop in front of our eyes. But yes, while we say that the human factor is extremely important, but equally important is the fact that today digitization is making efficiency a lot more. So somewhere we need to have a balance where we say that the human face and the technology has to merge to see that the patient centricity becomes extremely sort of more productive in that sense. Again, if you look at the pharmaceutical industry change that I have seen in the 40 years of my journey as a clinician, right from being only a drug sort of somebody who just probably produced drugs, today it's become more a wholesome care. So I don't see just pharmaceutical companies that come and talk about drugs to us. It's become more like we have drugs, but we can also be partnered to you in terms of patient care. And that's very important. So when people reach out to me as a secretary and say, we want to partner with RSSDI, And I have all the pharmaceutical companies that reach out to me and say, we have got projects that we want to see, that how can we make patient as a focus, and the HCPs and the pharmaceutical companies come together to create an ecosystem by which we make the efficiency of the system better so that patients are looked after. That's a great partnership, I would say, right from being only somebody who would market drugs to us. So being part of our clinics is always welcome. Being part of the journey that we enforce care to the patient is equally important. That's something that I really welcome from the initiative of what the pharmaceutical companies want to do with us. Again, we know that there are a lot of limitations of the current healthcare system that we've got. And you can see that although we have a vast majority of population all across the country, but access to care is disproportionate and limited. And that brings a lot of disparities in treatment that we give to our patients. We have a very inadequate healthcare infrastructure, and we know that while a lot of good infrastructure exists in the urban setups, the same is not true when it comes to rural sectors. And even within the urban sectors, if you walk across the entire country, and I travel all over the country, I see that the uniformity of care is not the same all across. And then, of course, we have a scarcity of trained professionals, and that's where it becomes a big challenge when you want to build teams up for care. Today, it's not just like me who's the only sole agent which looks after the patient. We have to build teams. I need a team where I would have a nutritionist, I would have a counselor, I will have a nurse practitioners. I will have my subordinates who will be the bridge between the patient and me, who will look after everything that I sort of decide as a care plan for the patient. And equally important is the fact that if I walk across the country, will I find a trained diabetologist who can impart diabetes care as per the recommended standards? I will not find it uniformly all across the country. And that's a true confession that I would tend to make. So you don't have a uniformity of skilled professionals all across the country, and that becomes a shortcoming for all of us. Again, everything is dictated by the cost of care, and nobody better than you who can tell us that when it comes to price barriers, how often you're pressurized to see that you can meet the targets, to see that the cost becomes affordable, particularly drug treatments become affordable for the patients. And very often, a good drug fails not because the drug is bad, because it's not affordable and the patients cannot buy them. And this is true all across. Even if you walk across the entire globe, you'll find that similar problems do exist, but more so in our country, which is a very price-conscious society. Disease burdens and health inequalities are very important. And today, I'm just taking the example of non-communicable diseases, and particularly diabetes as one entity. And if you look at the burden of diabetes that we have in our country, we have close to about 240 million people with diabetes or prediabetes, which is diagnosed above the age of 18 years. We have almost about 59% of our population are undiagnosed or not even aware of the fact that they have diabetes. What is the national average of HbA1c? 9% today. Even if I can bring down by 1% my average A1C, I will be doing a huge service to the society by bringing down the burden of cardiovascular disease or stroke risk. What is type 1? Type 1 is used to be low. It's supposed to be overall 5% of the total population of diabetes. Today we have 9 lakh population of type 1s in our country, and we're increasing by 5% every year. For undiagnosed type 1, 1 in 3 child will lose because of lack of availability of insulin. And these are just statistics that I'm rolling out because I have access to these statistics. So it is a dismal thing that we've got, and that's where the fragmented healthcare delivery comes in. I mean, if you look at type 1, we don't have insulin for people who can't afford it. It's a lifetime insulin that we have to give these children. So we have philanthropic organizations, we have the government delivery systems, but again, these are sort of very, not very consistent in terms of delivery that we've got. So today, digital health does offer opportunity for India to leapfrog ahead and transform the healthcare. Some of the challenges that I just mentioned would be addressed by digital health, because we know that access then becomes easier through digital health. And that's where I say that when I look at the 40 years of journey that I've had, where face-to-face interaction is important, but it has limitations in terms of outreach. But with digital health, I can reach out to a lot more people. And today, if you look at the journey of all the digitization that's happening and the digital tools that are available for access and for imparting care, you find that it is so much easier now to treat patients. So you can improve the quality of care, reduce the healthcare costs, enhance healthcare access, patient education and medical adherence has become more important, improve the productivity of healthcare providers, and then, of course, early detection becomes a very key area that I'm going to touch base on a little later. Now, these are some of the digital health that is addressing the issues. We've got now good HMIs and EMRs, and these are sort of core clinical applications that enhance care in the hospitals and doctor clinics. Now, it has also helped us to get a lot of data mining out of these EMRs, because then we are able to understand patient characteristics through the EMRs. It also helps us to do a lot of statistical data analysis, as well as see the response rates of how patients behave whenever a particular treatment plan is enforced. Imaging has become better today with remote imaging reporting that people can do, and you can find that there is more accurate testing and diagnosis of the patient health condition that we can have. Data interoperability is something that we have been always stressing on, and this is something because all of us have data. I'm sure within this room, everybody who's sitting here on their computers will have data. But the question is, how are we utilizing this data? That is very important. Can we share data with each other within the boundaries of certain rules that we can have and make this data more reproducible, more interactable, and see that can we make policies which will be based on what data we collect of the Indian population. Today, the sad reality is that if you want to get a data bank of the Indian population, we don't have it. There is data. It's not there, but it's lying in silos lot of places. So can we integrate all this data and bring it all together to make a robust policy that would be true for our own population? And that's been one of our driving thing, from the RSSDI, that what can we do for the data of Indian population related to diabetes. Then telemedicine has, of course, made it easier to have now outreach. We have set up a village adoption program. We have got a district coordinator network from the RSSDI, and we have got 800 district coordinators mapped out all across the country representing districts. The reason why we did this, and going down right up to the taluka level, is because we do understand that the expertise at the last mile is not very good. So can our members, senior members from the organization, reach out to all the peripheral networks and see that education of the HCPs, as well as health awareness and patient awareness, can be dictated through these network that we have created from the RSSDI. Analytics, of course, is very important, and talk about this a little later, that whatever data we collect, it may be in any form that the data that we gather, the analytics of that data becomes extremely important to make it very producible. And we need clean data to make that useful for us. For example, I'll tell you, we did a program called as Defeat Diabetes, and this was done just after the COVID or during the COVID times. I think it was just after the COVID that we did. And we said, how many people have actually tested their blood glucose during their lifetime to know that they have diabetes? And let's bring up a diabetes testing or glucose testing awareness amongst the people. And that was the entire drive that we had. And we said, can we reach out to 100 million people in 100 days? We thought it was ambitious at that point of time. But to our surprise, through various medias, we were able to reach out to 128 million people in 100 days. And even more important was the fact that we did actual physical blood glucose testing of 1 million population in a single day with the help of many agencies. But the setback was that we were not so educated enough to collect good data. So although we did a testing of 1 million population, we could get good, clean data of only about 30,000 people. We published that paper in one of the international journals, but we lost a lot of data. So getting good, clean data is extremely important, and a structured, federated data that you can get, which will help us to make all the analytics possible. Personal empowerment. Now, today, every patient is educated, and every patient wants to know about his health. Even the person who's uneducated in the rural sector has a certain amount of intelligence to say that when he comes to us and say, what have I got? Gone are the days when you say, you take this medicines and go away. Doesn't work anymore today. Everybody wants to know, what have I got? And in a way, it is good, because if I sort of plan a treatment for that person and explain to him that he needs to follow this kind of a treatment plan, if he understands, I'm sure that he will do it. Otherwise, there was no guarantee that this was possible. So access to information has improved, and this access of information can be through various platforms that are available today. There is an active engagement. Obviously, there are a lot of apps and tools that are available within the social media space and otherwise, which makes it possible. Patients want to be an active participant of their healthcare journey, and that's very important. That's what I talked to you about. So I cannot tell them, just take this drug. If a company comes and tells me, these are the indications, just give this drug. That doesn't work. I have got to tell them why this drug needs to be given to that particular patient. Right? I have to know that drug myself, and then I can tell that person that, okay, this is what you need to do, because this works, and these are the setbacks that you can have with that drug. So being educated myself is equally important if I have to sort of talk about it. And then, of course, the digital shift has made a more informed and empowered decision to be made. So it's not just when I look at something. Today we're talking about predictive analysis, and we're talking about, can I make a prediction of somebody getting a diabetes or a pre-diabetes even before he's on that journey. We know that 15 years before the onset of diabetes, people are already showing signatures which will predict that somebody will become a diabetic at a later point of time. But can we identify those signatures based on the data collection that I can do of an individual if he has been regularly following up with me, and I can map out his adverse signatures to tell me that this patient is going to develop pre-diabetes or diabetes at a later point of time. So this is very important, how analytics will tend to help us. So today, the key drivers of personal health empowerment is growth of digital infrastructure, changing individual behaviors, and then, of course, availability of digital health information. And this is all through various digital apps and tools that are available today that will help us. And of course, the government platforms are improved. We've been interacting with the government machinery, with the National Digital Health Mission, with the Ayushman Bharat. They have been creating a host of digital tools that is going to be all across the country. Today, nobody is more powerful than the government of India to see that how can we reach out to every part of the country. And we have been making it our mission to work with the government of India to see that digital tools are available all across to every person, to every doctor. And we've got platforms like Aadhaar, UPI, CoWIN, ABDMs, and we have been working with the National Health Authority and seeing that whether we can impart digitization of healthcare, at least when it relates to diabetes as concerned. There's been, of course, as I said, there's been a rise of non-communicable diseases. So as the rise goes up, the requirement for all these tools are also going to go up. And it's time that the pharmaceutical industry also joins hands and says, okay, I'm not just going to sell drugs. I'm not going to just develop drugs, but how can I be part of the patient's journey to his well-being? And this may be a good way that you can partner with the doctor and say that, okay, I'm going to partner and see that the patient's well-being is a more important endpoint rather than just selling a drug, which is not going to be just, this is going to be just one part of the whole ecosystem. As I said, that doctors have to be empowered to think. And if I walk across and say that how many people actually keep abreast of knowledge, that becomes a little difficult because in the day-to-day practice, day-to-day life of an individual, the challenges that a person faces, they all fall back in terms of knowledge retrieval or knowledge gathering. So that's where perhaps the clinical decision support systems comes to use. And we find that we've got a lot of clinical decision support systems that are available today online. We've got apps, we've got wearable devices, we've got telehealth services, we've got data-driven insights that can be done. And all these wearable devices now have become potential ways by which we can gather information and make it useful in terms of analytics. And even simple things like CGMs that we use, or you've got the iWatch and all kinds of things that are gathering data. So we've been looking at how can we get data on the Indian population. And one of the ways we said, okay, let's reach out to the glucometer companies and say, can you share what is the glucose profiles of individuals? Because today we've got all connected glucometers. Can we reach out to the CGMs and gather data from the CGM companies? Can we reach out to the labs and look at the HbA1c values of the individuals that come to large labs and see what is the profile of these people who've got high A1C values? We've been reaching out to various people to see that, okay, what about prescription patterns that we see? So we reach out to the online pharmacies and say, okay, can you share data with us and say what are the prescription patterns that people tend to have when it comes to the various profiles of clinical profiles of individuals that we've got. Personalized care. So patient centricity is important that the doctor should be well educated. And if the doctor education has to happen, then we've got to have an engagement by which we can educate them well. And thankfully, there's a lot of education that goes on in our country. And part of it, I think I would like to thank the pharmaceutical industry for making that possible. You do a great job doing that through your support for various meetings, high quality meetings that you support, as well as you drive a lot of high quality meetings, which makes education possible. So I would really thank all of you for that. But we've got tools today available. We've got patient portals. As much as doctors need education, patients also need education. And today there are a lot of online tools for patients to go and visit them and get education. And I think you have that opportunity that you can develop a lot of patient care tools and good education, because that will help patients to understand a bit about their illness. And remote monitorings are become now today the order of the day. For example, I'll tell you that I get patients who are not confined to my city. I get patients who come from faraway cities. It is very difficult for them to travel every time and come and see me, particularly if they want to get a change of dose done or change of treatment done. If I'm monitoring them remotely, their glucose values, or by continuous glucose monitorings, I can remotely monitor them and tell them how much of insulinization they need to do. If they are getting asymptomatic hypoglycemias, I can pick them up at my clinic and say, my team can call them up and say, you don't realize it, but you're getting a hypoglycemia unawareness. You need to modify your doses. So remote monitoring has become a great boon for us in better patient management, and that helps a lot. So what is CDSS? It's basically just an evidence-based digital tool, point of care, where clinicians need to make diagnosis and treatment decisions. Latest evidence and best practice recommendations are available from global experts on these platforms. And there is an easy access. It may be through your computers, mobile devices, or EMRs. And there's a consistent source of information. What is important is whatever tools are available for education, they have to be upgraded and updated all the time. There is no point you develop a tool, and this often happens that somebody takes it as a marketing initiative and say, I've got this tool available. Let's reach out to the doctors and make them use that tool. Now, there is a change of leadership, or there is a change of plan, or whatever it is, that platform stays stagnant, and after a point of time, there is no upgradation or updation of the knowledge that happens out there. So it is important that you develop consistent patterns of learning, which is updated to global knowledge as it stands today. This is just one of the sort of things that I found, that a clinical topic is assessed 1,200 times a minute worldwide, and there is almost 650 million clinical topics that are viewed every year. So that's the kind of reach that the clinical decision support systems tend to have. Now, in the next sort of couple of minutes, I'm just going to tell you how is RSSDI meeting the challenges of today's world in terms of digital health. And this is a 5-year vision that we've already mapped out, looking at what RSSDI should do for the patients with diabetes or population with diabetes, and how can we forge collaborations and see that we can move ahead. Now, we did an internal tech survey that how much are people educated in terms of technology, and we had an outside agency which mapped out this tech survey for us. And what we found is that the proportion of doctors using clinical management systems, only 39%, okay? Proportion of patients using digital tools are even fewer. It's only about 19% today. If you look at the digital tools used, the clinical management or clinic EMR, 39% as I told you. Online appointment billing system, 19%. Clinical quality of KPIs, 15%. Risk calculators, 14%. Patient education and support apps, 11%. Telemedicine platform, 9%. And remote monitoring platforms, only 7%. So that's the penetration of technology that we have today in India. And this database was collected from all across the country. We're going to publish this data, but this is just unpublished data that I'm showing you, that we got it independently accessed from all across the country. This is the tech penetration as it stands today. So what we did was, we said we need to do a digitization mapping. And we need to see how is RSSDI going to shape up for the future. And we sort of joined hands with Quetta Foundation. Today, I'm proud to say, for the first time, any scientific body has now taken the step ahead. We have partnered with Quetta Foundation, and we are going to be housed in the research park of the IIT Mumbai. So we are setting up an office in IIT Mumbai, and I've got the CEO, Dr. Bhagwati Prasad, out there, who's an alumni of IIT Mumbai, a PhD in biotechnology, who's the CEO of our unit. So RSSDI has now set up a complete unit of digital health in the IIT Mumbai campus. So this will sort of facilitate a lot of interaction between the healthcare, the technologists, and the engineers who design the platforms, and as well as foster a lot of research that will happen to encourage all these activities. So this is a framework that we are going to do, and I've just mapped it out. It's a busy slide, but we have looked at our 5-year horizon of what we want to do for the population with diabetes, and this is going to be the map that we are going to be following across. But in a nutshell, what we are going to do in the next 12 to 24 months is, we've got a digital diabetes team, which is going to form a strong technology team under RSSDI to drive digital diabetes initiatives. And we have set this office up, as I said, at the KCD stands for Quetta Center for Digital Diabetology. That is our RSSDI KCDD initiative together. Then we're going to come up with, of course, the Diabetes CMS initiative, which defines diabetes requirements, selects RSSDI empaneled CMS vendors, and drives CMS adoption. There will be an RSSDI certification, and we'll be, of course, looking at interoperability and clinical metrics. We're going to do diabetes control initiatives where we're going to define diabetes requirements, select RSSDI empaneled diabetes control and glucose monitoring apps, RSSDI certifications. Then we're going to do a lot of device initiatives. We're going to define standards for devices and empaneled approved devices for glucose monitoring and other areas. We're going to develop digital toolkits. We're going to become cost-effective patient-doctor toolkits. So it may involve health devices, software, EMR integrations for integrated diabetes management. And then we're going to do a lot of training, capacity building for digital health training programs. We're going to develop diabetes registries and, of course, foster a lot of diabetes research. So this is our roadmap for the next 12 to 24 months that we're going to be doing. We have developed a digital health foundation courses so that we educate doctors about digital health. And this is our roadmap now. The next thing that we're developing is to see that how can we educate healthcare professionals about digital health, and we are developing a modular course which is open source, and we're going to put this out, and we're going to do a lot of learning initiatives when it comes to digital health. And these are just the course content that we're doing. what is digital health, EMR, and these are the components of that. It's being developed by some of the best partners that we've got from the technology space, from the education space, as well as from the healthcare that we're going to be doing. So this is our entire course that we have developed, introduction to ABDM. So we are going to get the NHA people to come and talk to us about how ABDM can be integrated with us, telemedicine, and then of course advancements in digital diabetes management that we're going to be doing. Another thing that we've sort of now come up is that we need to standardize care. We need to have certain metrics of standards that we say that this is a high quality care clinic which imparts everything end-to-end solutions to a patient. We are very happy to announce all this. The formal announcement is going to happen next week in the annual RSSDI meeting. But we have signed an MOU with the NABH, and we are going to come up with NABH certified diabetic clinics all across the country. And this is our partnership that is going to be declared next week in Delhi in our annual meeting, where we're going to formally sign an MOU with them. And this will now help when we see that there will be a quality standards that are going to be established for diabetic clinics, and we're going to have NABH certification of diabetic clinics that will be possible, which will be independently monitored and assessed and periodically reviewed to see that they maintain the standards of care across the country. We've also partnered with the National Cancer Grid. The National Cancer Grid is funded by the Department of Atomic Energy. It is housed in the Tata Memorial Hospital, and they run the National Cancer Grid, which is a conglomeration of 300 cancer hospitals, a lot of cancer specialists, which sets up a lot of protocols of care. This was a signing of the MOU. That's Dr. C.S. Pramesh, who's the director of Tata Memorial Hospital. That is Dr. Rizwan Quetta. He's the chairman of the NABH board, as well as he's the founder of Quetta Foundation. And these are the areas of focus that we're going to do, and we're going to develop the National Diabetes Grid across the country, just as the National Cancer Grid, which is going to be piggybacked on what the standards for the National Cancer Grid is. And this is going to be development of clinical guidelines, comorbidity protocols, research, capacity building and training, education, and digital health. Of course, analytics, as I said, is going to be one of the key areas that we're going to be looking at. How can we collect all this data together and make meaningful analytics out of it, which will be very useful in driving high quality care for our population. If we can bring this analytics to you, it will help you to see what are the patient patterns that you can look at, and how can you do drug development and delivery systems that will help us to sort of manage our patients. So if we can improve drug development within our own country, and if we can have better delivery patterns or delivery devices, then obviously our job becomes much simpler. So there will be a lot of data-driven analytics that will be done, and these are some of the snapshots that we are talking about. Today, as I said, we are all up in the first lot over here. We all have data in silos. We are not interacting with each other. We try to reach out to Harvard. They have some system called as I2B2. We try to adopt the I2B2 system from the Harvard system, but it was a bit challenging for us. So we're now developing our own. We're trying to see that can we centralize data, and then of course we put it into an enterprise data warehouse by which it can be collective data that we can put together, which can be then shared, and everybody shares and everybody contributes. A pattern that we would like to do so that data collection can be done across the country. I just want to end up by giving you how all this thing is really going to help us. I mean, I've talked a lot of things which are futuristic, which is all on the roadmap. But what will it really mean at the ground reality? So let's look at scenario one. You've got a Ram Kumar, a villager diagnosed with diabetes, can receive quality care and advice through mobile and web healthcare applications, eliminating the need for frequent travel to healthcare facilities. Here's where web healthcare application does more than 5 lakh teleconsultations a day. All right. You've got a second scenario where personal health records will provide a centralized platform for patients like Ramaya, who's moved to another city while pregnant, with digital health records, and there's no issue of important details being missed out. So there is a complete health repository that person just carries with him. And That's where probably the ABDM platform will be very useful, and ABBA IDs are now getting generated for everybody so that you give your own ABBA ID and you can collect your own data and keep it with you. You're the owner of your own data. That's most important. You have a third scenario where you can do seamless exchange of data. I go to a clinic, I want to have my data seamlessly exchanged, or I can exchange data for comparative purposes. There's no loss of data that can happen. Or scenario 4, where you've got online resources, directories, and telemedicine platform, which it makes it easy to find good quality care. And that was our purpose, to partner with NABH, that if somebody wants to look in the city, which is a good diabetes center, all it does is look at NABH accredited diabetic clinics and able to find out across the city which is a good center for treatment of diabetes as such. And then, of course, you can share knowledge, you can do a lot of timely diagnosis, you can do a lot of predictive analysis that may happen so that you can map out the roadmap of somebody. I'm just going to sort of touch base because you are a better expert than me about this. But what is optimizing pharma strategies should be that it should have patient-centric messaging, but it should be in collaboration with the healthcare, because what happens is very often anything the pharmaceutical company tries to push gets perceived as a biased content, and that becomes difficult for adoption purposes. So if you do it on the background of a healthcare body, it sort of brings out a neutrality of content which becomes easily adoptable. But when you sort of reach out and say, I'm doing this as part of the pharmaceutical initiative, it always gets perceived as a biased content or a biased approach that may happen out there, right? You need to have a very targeted outreach program where you're leveraging the data and analytics to identify and engage the right HCPs and make your every visit very relevant and productive. That is very important. I have a lot of people who come and visit me, but they may visit me sit with me and talk to me about 15 minutes, the net productivity is hardly anything. And yet I may have just somebody who comes and talks to me very focused, comes prepared and does the homework. In 5 minutes, you've done a lot of work, which is highly productive. Omni-channel approach, today with all the integrating digital and traditional channels we've got a seamless personal experience that is possible. As I said, that today you're not just somebody who sort of develops only drugs. You're part of the patient care journey, and you're part of the healthcare system just as we are, and we are all in one ecosystem. And we need to work with each other, we need to partner with each other, and we need to see that how can we best improve the healthcare systems of the entire country. So that's my last slide, that as the healthcare landscape continues to evolve, embracing patient centricity will be crucial for pharmaceutical companies and HCPs to deliver more personalized, effective, and engaging care. By leveraging digital technologies and fostering collaborative partnerships, the industry can enhance patient outcomes and position itself for long-term success. Thank you very much for your patient listening.
I must say you had a wonderful presentation and you could summarize, and I think we can just have lunch and go. But having said that, this question is more from a pharmaceutical professional, and I also did my research in digital marketing and my PhD is on that. My question to you, Dr. Sanjay Agarwal, is what do you expect from pharmaceutical industry, especially when they make a visit? I know that you made a quick note of 15 minutes versus 5 minutes, but what is that you expect? What is that you should surely want any kind of communication, whether digital or physical, to be avoided, and at what frequency is something which you are comfortable?
Okay, I think a little out of context of what I spoke, but I'll still answer that question for you. Let's take a typical day that I face at my clinic, all right? I have, of course, got a very busy day at the clinic looking at patients, and I obviously also meet the industry very regularly and talk to people. Today, your field staff becomes the face of your company and the ethos of your company, right? I would like to see an educated representative that talks to me rather than somebody who doesn't know anything right? Or has been trained internally but does not understand what he's talking at all. So I want somebody who will come to me, be very focused and telling me something which I would like to hear, and he can sell that to me in within 2 minutes, or he may spend 15 minutes and he may not be able to sell that to me at all, right? We need to have people who become part of a clinic journey, part of a patient care journey. Can you help me? Now, if I've worked in the Jocelyn system at the Harvard, where we've got the pharmaceutical industry that comes and becomes part of the clinic. They help out. They say that, okay, what is the patient care that they can become part of? And they are willing to ask us that, okay, what care that they can provide which will help the patient and the doctor, can we become a bridge to that? Right? We need to see that whatever you do, it is meaningful, because your time is as important as our time. I hate to see people wait for me, that they're waiting for 2 hours and 3 hours to see me, because it's a loss of productivity for your people. It's nice to see that, okay, if they meet me even once in 2 months, I remember the product. He doesn't have to come and engage me every week or every day wherever I am, or accost me in the hospital when I'm passing by. It's so much of loss of time, energy, and I don't like to see them waiting for me. They need to have a very focused message that they need to give to a healthcare professional. We did that on our behalf. What we did from RSSDI was, and a lot of companies took advantage of it. We said, let's not get into that discussion. I said, we will train your field staff. And we did that. We did for 3 or 4 companies, where we trained almost to the tune of about 2,000 to 3,000 field staffs and gave them an RSSDI certification of training all about diabetes. And that changed them completely, the way they approached a healthcare professional. Today, we are very happy. Let's say some of our surveys that we did it with the assistance of pharmaceutical company. We said, you got your iPads with you. You got your, today nobody uses the paper visual aids anymore. I see everybody with iPads. I said, can you come conduct a survey from me? You go to every single clinic all across, just sit there and with the permission of the doctor, can you collect this data for me? You can do that for an individual clinic, his own data. You can say, okay, I'll sit in your clinic, what kind of a data you want from me, I will sit here and collect the data for you. Which in itself, the doctor can then realize that what is he doing or what kind of a data he wants, and he can get solutions to it. So what we are asking you to do is just make the time meaningful for you and for me. That is very important. Have an educated person who's focused in what he wants to speak. There is no point in talking to me about 15 drugs in one visit when I won't even retain one drug. And commonly they're told that you need to say this 10 drugs which I've been instructed to speak at every visit. I've lost him on the first drug itself. Right? So it's better that he talks one drug, but he's focused on that one drug to sell it to me. So I think our education through the field staff has to change, our mindset has to change. And the policies that at the leadership level that you do has to be more mindful of the fact that as much as it is important for you, our time is equally important. Right? Thank you.
Hello, Dr. Sanjay. I have one question from you. Since you said there should be neutrality when pharma companies approach you for a particular drug or medicine, and it's also equally important that I should be educated myself. So I would like to ask you which digital tools you use as a healthcare professional to upgrade yourself apart from the pharma companies, and how do you see that role revolving? I mean, being part of RSDI, how it is going to evolve in the future?
Yeah. So I think for us, at least at a senior level, we read a lot of journals that are possible, right? So we read through our journals. We read through some of the clinical decision-making systems like UpToDate that is available for us. And UpToDate is constantly updated all the time in terms of the knowledge bases. Meetings are an important source with the interactions that we tend to do. I do a lot of research, so research and interaction between research is very important. But let's go down to the average individual who's not involved in so much, because I do a lot of publications, I do a lot of writing work, I do a lot of research. So I'm forced to look at all these things in terms of what I want to collect. But an average doctor probably does not do so much of reading. He looks at how he can make his, whatever limited time he's got, into a more meaningful. So he's happy getting ready-made information for himself. So if you can collect good ready-made information unbiased, and I'm giving you an example again, what happens typically when we arrange a high quality meeting and the pharmaceutical industry is part of that meeting, a lot of scientific content gets sort of pushed back because you want to push an agenda of a drug. And I don't blame you for that at all. And that's a part of your job. You need to do that. But what happens is the science gets backsided. So if people are coming to listen to science and they ended up getting 50% of talks that are drug driven, you will not find them in the auditorium at all. So there has to be a balance that whatever you do, it has to be scientific and science driven rather than promotional in nature. Yes?
Doctor, I have two questions. One, you said that the average HbA1c of India is about 9. It seems to be very high. So is that any particular population which has been surveyed to get this? And the second is, we were talking about the CGM and a lot of diabetic 1 patient, the children are coming up. Now, though there are a lot of systems are coming in, but I have a couple of friends and who are really struggling with their kids having the type 1 diabetes. And I feel that it's not yet very easy and accessible, the all CGM systems, where these parents need to, get up midnight and monitor their blood glucose level. So how we can ease out this usage of CGM so that large population will get beneficial easily?
Okay, so let me answer your second question first, that how can we make CGMs more adoptable, if you're right, if I'm right in just putting it in a nutshell. Yes, HbA1c, SMBGs and CGMs, they all complement each other. They don't replace each other, number one, right? CGMs are a good way by which I can see the entire glucose profile of an individual, because all type 1s will be on insulin and basal bolus therapies, and that helps us to map out that what should be the insulin dose that I need to give this patient. Also equally important from the patient's point of view is that whatever food the child is eating, how does it work on the glycemic curve? It helps that child to know, or the mother to know, that if I am preparing certain kind of food, what happens to the glycemic values of that particular child. And if I can tweak that preparation and I can bring the glycemic values down through food moderation, then obviously the insulinization becomes much easier. The challenge that happens is, today we have the AGPs which are 14 days. We have already done away with the previous ones which were a shorter duration of time. Today we are adopting the only one which we have available is a 14-day one. The cost becomes a limiting factor for us. So unless we start now developing cheaper systems within our own country, and I'll give you what we have been trying to do. We are collaborations with JDRF, that's a Juvenile Diabetes Research Foundation, is housed in Australia and US, and we are collaborators. RSS is a collaborator JDRF. JDRF said two things. JDRF primarily is an organization which is driven by parents of type 1 diabetes, and it's entirely funded by international bodies, a huge funding that is there. Said, okay, can we develop a $100 pump which will be affordable to everybody? And we've gone out, we did a hackathon, a technology hackathon, to see that can we get tech companies and tech institutes to partner and find a prototype which will develop a $100 pump for us. And I'm sure in time to come, we will have our in-house strengths because we have the brains. We will have cheaper alternatives, and perhaps this is a business opportunity for the pharmaceutical companies to invest in, to find out that can we do device developments other than drug developments, which will find a mass appeal and as well as a business opportunity for you. We have the technology companies that are there. We have the tech people that are available. All we need to do is, reach out to them and say, let's do something together. So we have worked out with triple ITs, we've worked with ICERs, we've worked with ISECs, and trying to see that can we do a lot of device developments. We are, through the KCDD, we are trying to do device standardizations so that we don't sort of come up with anything that is non-standardized. But it's there, we have it, but all we need to do is reach out to them and make the development possible. Some of it is already on the roadmap.
Sir, I have one question. In your presentation, let's consider this that there are two bodies. One is pharma marketing, that is a pharma company, and another one is HCP, that is a hospital or nursing home. So when it comes to pharma marketing, where you would like pharma marketing to stop? Because when we call as a patient centricity, how much you would like pharma company to come closer to a hospital or a HCP, and you say that no, this is my domain, you have to stop here. And otherwise there will be, when it comes to patient centricity, there will be good chances of overlapping. So where pharma company should stop and the HCP would like to have the support?
I think it's a tough question to answer, honestly. The lines are very blurred and you can't have a clear-cut one way or the other that I can really speak about. Let's say one thing. For the patient, the doctor is a face, right? And the patient trusts the doctor and the healthcare system far higher than anybody else as such. So whatever we are able to help the patient in its journey with an illness, it's always welcome. As I said earlier, that the pharmaceutical company obviously in one hand is doing all the drug development, drug marketing, drug everything that is possible to make those drugs available for us. And which is why we are able to now give a much better care to individual patients, because we have got so much of plethora of drugs that are available that can. So today to have an uncontrolled diabetic means probably you're not doing something right, because you've got so much of drugs available, right? So drugs are there. It's a question of educating the right drug to be given to the right patient in the right dose. That is extremely important. Let me tell you something very clear, right? Despite all the education, and this is just a reality I'm talking about, and maybe sort of talking a bit about our own population of healthcare people, nobody does a prescription audit. Neither does a pharmaceutical company. That at the end of the day, if you're coming out with a good product and a healthcare professional is not educated enough how to use that product and use it in a bad way, not the prescribed way, and it doesn't get the required effect, the drug gets a bad name for it. It's not that the drug was not good, it's just that it was not used in the right manner. Now, if your field staff was not educated enough to tell the doctor, who's not read about it adequately, and he does a wrong approach to that doctor, obviously the results are not going to be there. Right? So that's where the education of your field staff and the doctor becomes crucial. Today I find that you'll have 3 secretagogues, you'll have 2 sulfonylureas, 1 glycinide in a single prescription, or you'll have 2 DPP-4 inhibitors in a single prescription. There's no rationality. Or you'll have 2 basal insulins in 1 prescription. How would you justify that rationality in any kind of way? Despite all the education that may happen, right? So we are falling short somewhere. Despite all these education that we do, we are not auditing our own prescriptions to see that. I don't think if there is a good conscientious doctor and he does something wrong out of maybe lack of knowledge, that you go back and tell the doctor and say, look, you wrote this prescription. You have access to all the prescriptions. It comes to you one way or the other. And you find prescription patterns of doctors which reach out to you. If somebody is making a mistake, I don't think it's not possible for you to go back and say, look, this could have been done this way, in a gentle manner. That will correct it for the next person. Right? Same time, as I said, that don't overindulge with the doctor because his time is valuable. His time is taken up more by patients rather than meeting people. So if you make a visit, let's say every week or every day, you're taking up a lot of my time. I'm not very happy about it. I would be happy if you meet me once a month or once in 2 months because that drug stays with me. And if I get everybody coming to me that way, I'll be able to give more meaningful time rather than just a 30 seconds or a 1 minute to that particular person.
I'm Dr. Talha. The talk was very exciting, especially all the plan, promising and full of hope. So I've got just 2 small questions. One thing is, how do you plan to have those satellite centers? Because recently in the Diwali vacation, I was also in one such Konkan area, and where I've been going because it's my in-laws. So there they always visit Mumbai. They have to either come to Mumbai or Pune whenever they have any requirement, and many patients have lost their lives because of that. So how do you plan to establish those satellite centers across India as a part of your plan? First thing. And second thing, prior to my question, there was a discussion of what goes into the prescription. So what are we doing to educate, or what is RSSDI planning to do to educate the GPs, which majorly manage the patients across India? Because we still see, even after all these drugs, the sulfonylureas and the biguanides are still the most prescribed medications for diabetes. And the cutoff or the HbA1c value that you said average is not what is acceptable. So what is that RSSDI is going to do in that regards? Educating GPs and those satellites.
Because I've run out of time and Swati is waving her hands out there, I'll just take 30 seconds to answer your question. We are, for our outreach clinics, we are doing digitally now, as well as we've got minimum care program that we are developing. And this is being done with partnerships with a number of stakeholders, where we are going to reach out to villages, talukas, and see that how can we educate doctors and patients out there. We are trying to get the delivery system not by we delivering healthcare at the doorstep, but we're going to educate the doctors out there within the community to become more productive and have a better idea about how to deal with situations. When it comes to expert advice, we will have all our people will be supported from the organization to do that, right? 2, in terms of education for doctors, we've got on our website, if you see the website of RSSDI, we've got free learning system, and it's an open source. We've got a lot of training modules out there. We are also doing a lot of state chapter meetings. We're doing national meetings, and a lot of pharmaceutical companies have got high quality meetings that happen. I'm sure there's a lot of provision of education material that goes out to them. It's upon the individual person how much he can grab for himself and educate himself. If a person doesn't want to do it, you may provide everything to him, he's not going to do it for you, right? But the provision is all there, it's all free, you don't have to pay for it when you go to the RSSDI website. We also got patient awareness sort of infographics and videos that are freely downloadable. We spent a fortune on it to see that we've got 12 different languages that are available on the website, and it's freely downloadable to be given to anybody. So we've done all the things. Go to the website, you'll find everything there.
Thank you so much.
Thank you very much. Thank you for your patient listening. Thank you.
You've actually shared a snapshot of a roadmap of patient-centric growth right from blood testing to data analytics, and how do we foster good quality care at each and every level. Thank you, Doctor. I call upon Dr. Swati Sinha from our organizing team of Pharma State Academy and Mr. Varun Belgudri from Walters Kluwer.